Hello, welcome to week one. This is the content session for week one. This class or this session is for the NU 621 Advanced Pathophysiology course. My name is Dr. Christy Burks, and we're going to get started. Now, each week of this course, you will have a quiz with the exception of week 8. So some of the things you should be doing before you take that quiz is completing the reading assignments, making sure that you are reviewing those presentations or videos that are listed there, and reviewing the supplemental PowerPoints, watching the content sessions, and then utilizing whatever study techniques works best for you, whether it's taking notes, doing flashcards, concept maps, but definitely studying this before you take that quiz. All right, looking at our course objectives for the week. Please note that each week you will notice the course objectives are the same. However, our body systems and disease processes change for the week. Remember, at the end of this week, we should be able to, one, integrate nursing and related sciences into the delivery of advanced nursing care to diverse populations. We should be able to incorporate current and emerging genetic and genomic evidence in providing advanced nursing care to individuals, families, and communities while accounting for patient values and judgment. And then lastly, compare normal anatomy and physiology to those alterations in function and regulation of body organs and systems in response to stressors. I did want to point out the resources that you have. Of course, we have the textbook, whether you're using the physical book or if you do have access to the ebook, you have access to functions like highlighting the bookmark information. You can do the read aloud option, which is great if you are commuting. There's a way to create flashcards, and then you can actually put it in a study mode as well. And then I wanted to talk to you about the supplemental PowerPoints, which correlate to each chapter that we are studying for each week. So making sure that you're looking at that. You can locate those in the synchronous session schedule and links announcement every week. They'll be located there. Then we have access to what the library, if you go to there's a couple different ways to access these three Ps. And that's for advanced pathophysiology, advanced pharmacology, and advanced physical assessment or assessment. So when you're taking these courses, you have access to these additional resources to help you with understanding the material and even studying. So making sure that you're utilizing this is a great tool. So, like I said, there's a couple different ways. You can go to the library link and access there. I think that going to the course, this is probably one of the easier ways to find this. If you go to our course, you go to modules and then click on the Read Me First at the very top. It's the first module available to you. Go to that last page of this module, and it's directed for the NP students only, but everybody has access to this. It's the Introduction to the APEA Question Banks and Exam. Here you're going to find a study guide that everyone is welcome to utilize, as well as the link to the library 3Ps. Now, the resources on the ebooks that you have access to are additional ebooks that you have access to. One is the Color Atlas of Pathophysiology. You have Just the Facts Pathophysiology ebook, the Mosby's Pocket Dictionary of Medicine, Nursing, and Health Professions. And then finally, if you're a visual learner, this might be a little bit helpful to you, but you have access to the ebook of Pathophysiology Made Incredibly Visual. This is what those links look like. So it's right under on that. If you go to that last page and then scroll down, you'll find those two links to one, the study guide, and then the link for the library 3Ps. Okay. All right, let's move on and get started on the content. So this week we're going to look at or start with restrictive versus obstructive lung diseases. So when we think of restrictive lung diseases, what are some examples? A few examples include aspiration, atelectasis, pulmonary fibrosis, pulmonary edema. You have acute respiratory distress syndrome, and then even some of our chest wall disorders. Think of obesity, scoliosis, things like that. Now, some of the characteristics include that decreased compliance of the lung tissue, where we see that stiffness, And in these patients, they require more effort to expand the lungs, making it harder to breathe in. This actually makes breathing more tiring for the patient and causes an increased work of breathing. So some of the signs and symptoms that we see is that dyspnea, tachypnea. Um, you have that decreased tidal volume, which, if you remember, is the amount of air you're breathing in and out. With each breath, it is smaller than normal. Okay. Versus if we look at obstructive lung diseases, we look at examples like COPD, asthma, pneumonia, and even tuberculosis. So when we think of, there are some conditions that can have both that restrictive and obstructive components. One example is that bronchostasis. So that's something to consider as well. But when we're looking at obstructive lung diseases, those characteristics include the narrowing of each or of airways, which result in obstruction in the airway that is worse with expiration. So that means more force is required to exhale a given amount of a volume of air, and that's due to that narrowed or blocked airways. So that increasing the work of breathing, and the patient has to use those accessory muscles during the expiration. So we typically see that decreased forced expiratory volume in 1 second. So that FEV1, we see that air is trapped in the lungs, results in that decreased tidal volume, which eventually leads to hypoventilation and hypercapnia. We see changes in the alveolar ventilation, resulting in that VQ mismatching and hypoxemia. And some of the areas, or some areas of the lungs may actually have good blood flow or perfusion, but insufficient air. So that's due to that ventilation. While other areas may have low perfusion, but good ventilation, which leads to ineffective gas exchange and potentially that hypoxemia is what we see. So we see symptoms of that dyspnea and wheezing. Okay. Now let's quickly look at pulmonary function tests. When we think about pulmonary function tests, or PFTs, that are used to diagnose and differentiate between restrictive and obstructive lung diseases, we see these key measurements, which we talked about, the forced expiratory volume in 1 second, the FEV1, and that's the amount of air you can forcefully exhale in that first second. But there's also forced vital capacity, or FVC, and that's the total amount of air you can forcefully exhale. Now, in restrictive lung disease, we see on FVCs a decrease. In the FEV1, we see a decrease. And then FEV1 versus the FVC ratio, we see normal, or sometimes it can be increased in those restrictive lung diseases, but the lungs are stiff and can't fully expand, reducing that total amount of air a person can inhale and exhale. Versus our obstructive lung disease patients, we see normal or slightly decreased FVCs. We see a significantly decreased FEV1, and then that ratio of the FEV1 of FVC is typically decreased. In the obstructive lung diseases, that airflow is limited due to those narrowed airways, and that's what makes it difficult to exhale quickly. Now, there are additional tests like diffusing capacity, the DLCO, which can help further distinguish between these conditions. So DLCO is typically reduced in restrictive lung diseases and normal or increased in obstructive lung diseases. Now, these tests can help you determine the type and severity of lung disease, and it also helps us guide that appropriate treatment strategies as well. When we think about pulmonary function tests, you do need to know kind of each test and like what it is, what it's looking for. So just making sure that you're looking at that. We also have additional pulmonary function tests like your spirometry. So that measures the volume and flow of air inhaled and exhaled over time, with those key measurements, including that forced vital capacity and that FEV1. That again helps. The lung volume tests, where we measure the total lung capacity and its subdivisions like residual volume, vital capacity, and this assesses that lung expansion. We have the diffusing capacity, which measures the rate of gas transfer across the alveolar and capillary membrane, and that includes or indicates how effectively oxygen is moving into the bloodstream. You have the flow volume loop, which graphically displays that inspiratory and expiratory flow rates over the full range of lung volumes to identify airway obstructions. Pulse oximetry, which we are all familiar with, where it estimates oxygenation or oxygen saturation levels in the blood non-invasively using that sensor. Arterial blood gases analysis, so ABGs, and that directly measures the oxygen and carbon dioxide levels in arterial blood to evaluate the gas exchange as well. And all of these tests provide that valuable information about lung mechanics, capacities, and that gas exchange to diagnose and monitor respiratory conditions. So, one thing to remember so for example, on our pulmonary function test or PFT, severe asthma. So we think of severe asthma and we see that increased residual volume. So pulmonary function testing involves that series of tests that measure how well the lungs are working. So one of the main tests is spirometry, where the patient's breathing into a mouthpiece connected to a machine called a spirometer. This measures that total volume of air exhaled, where we see that forced capacity or forced vital capacity, the FVC, and that FEV1. The patient's instructed to take that big deep breath in and then blow out as hard and as fast as possible. So when we are looking at these, the tests are typically performed by trained respiratory therapists and trained nurses. Pulmonary function tests help us diagnose conditions, so like our asthma, COPD, restrictive lung diseases, and that helps us identify obstructive airflow or decreased lung volumes and capacities. So just remembering that, knowing what each one does. All right, looking ahead. So starting with obstructive lung diseases, let's look at asthma and the pathophysiology, focusing on the early asthmatic response and allergic asthma mechanisms. So when we're thinking about asthma, hang on just a second. All right, an early asthmatic response and that IgE production. In early asthmatic response, that plasma cells are produced, or they produce that antigen specific IgE. And IgE is crucial in the allergic asthma pathway. So that role of the IgE in allergic asthma, it binds to the FC receptors on the mast cells. This binding triggers that mast cell degranulation and releases of those inflammatory mediators. So that early phase response cells, we see the mast cells and the eosinophils are primarily involved in that early phase response during an asthma attack. Now, these cells, excuse me. So sorry about that. Mast cells and eosinophils are primarily involved in the early phase response during an asthma attack. So these cells release various inflammatory substances. So primary mediator of bronchoconstriction, sorry. Histamine is the primary mediator responsible for asthma bronchoconstriction in response to allergens. So it acts very quickly within 15 to 30 minutes of exposure, and we see that primary trigger for allergic asthma. Now, there are environmental allergens, which are the primary trigger for that bronchoconstriction in allergic asthma as well. Common allergens, if we think about pollen, mold, dust, animal dander, and even certain types of foods are what cause that primary cause of that airway obstruction. Now, going into the late asthmatic response begins right around that 4 to 8 hours after the early response. And we have the recruitment of eosinophils and the neutrophils and the lymphocytes during that acute response, which causes a release of the inflammatory mediators, again, inciting that bronchospasm, edema, and even that mucus secretion with obstruction to the airflow. Now, untreated inflammation that can lead to the long-term airway damage resulting in subepithelial fibrosis and that smooth muscle hypertrophy or that airway remodeling, and that can may become irreversible. So airway obstruction increases that resistance to to airflow and expiratory flow rates, and that decreases the expiratory flow that causes that air trapping or hyperinflation of the lungs and an increased work of breathing. So changes in resistance to airflow are not uniform throughout the lungs, and the distribution of inspired air is uneven, resulting in the VQ mismatch and hypoxemia. Now, hyperventilation is triggered by lung receptors responding to the airway obstruction and increased lung volume, and this results in early hypoxemia with that decreased PaCO2 and increased pH, which we see as respiratory alkalosis. Now, individuals are usually asymptomatic between attacks. Pulmonary function tests can actually be normal or show normal. And at the beginning of an asthmatic attack, the individual experiences that chest constriction, expectoratory wheezing, dyspnea, non-productive cough, sometimes that prolonged expiration, that use of accessory muscles in the abdomen and or our internal intercostal muscles. When we see that respiration, we have tachycardia and even tachypnea. Now, the Allergy or Asthma and Allergy Foundation of America has a wonderful visual that shows what is happening to the lungs when you have an asthma attack. So during that asthma attacks, we talked about several different changes we have or see in the what's happening in the lungs. We have that airway inflammation where that lining of the airway becomes swollen and inflamed. Then you have that mucus production where your airways produce that excess thick, sticky mucus. We see the bronchospasm where the muscle around your airway tightens and constricts. And then these three factors combined. And this three factors combined to narrow your airways, making them smaller and harder to breathe through. It traps the air in your lungs, causing a feeling of chest tightness. And then it obstructs the airflow, which especially when exhaling, so that reduces the oxygen intake and carbon dioxide expulsion. So as a result, again, you see patients experiencing wheezing, coughing, shortness of breath, chest tightness, or pain. This process can be triggered, again, by several different factors. We talked about allergens, exercise can induce it, respiratory infections, and it just depends on the type of asthma patients have. So in our bronchial asthma, we see bronchial muscles that contract or tighten, swell, and that mucus clogs, and air has that difficulty moving in or out. And that primary cause of airway obstruction in asthma, remember, airway inflammation and that bronchoconstriction. So again, this I think is just a great visual of what's happening whenever we see patients with that asthma attack. Now let's talk about COPD, chronic obstructive pulmonary disease. So obstructive lung diseases, that's the category that it falls into, which is COPD is characterized by that limitation of airflow. This is not fully reversible, and usually it progresses over time. So there are two primary phenotypes. The first is chronic bronchitis, and the second is emphysema. So starting with chronic bronchitis, which is caused by those air pollutants, which cause that hypersecretion of mucus, and chronic tussis, that chronic cough that continues for at least 3 months of the year for at least 2 consecutive years. This is because of the airways being swollen within your lungs. So the American Lung Association has patient education tools such as living with COPD, COPD basics, like steps to take when living with COPD. I show these to you, or I talk about these to help us remind you that these are wonderful tools and resources that we can utilize to help our patients understand what is happening in the disease process. Therefore, they grasp the importance of the medication and treatment adherence and compliance. So we see this in its continued destruction of the alveolar walls and pulmonary capillaries, which leads to pulmonary hypertension or cor pulmonale and cor pulmonale. So make sure that you see pulmonary hypertension section on this. COPD is an obstructive lung disease that impairs that gas exchange in several different ways. It damages the alveoli and airways, with inflammation causing that thickening of airway walls and that airway remodeling and excess of mucus production. So this mucus can actually block the airways, while loss of the lung elasticity hinders that full expansion. And these changes reduce the ability to effectively exhale that carbon dioxide, and that contributes to that CO2 retention and elevated PaCO2 in our COPD patients. COPD patients are also at risk for exacerbations, especially when acute respiratory acidosis occurs due to ineffective CO2 exhalation. So if we imagine your lungs are like a balloon. So with COPD, it's as if that balloon has become stiff and saggy and full of holes. So when you're breathing in, it becomes very difficult because the balloon doesn't inflate properly due to that stiffness. Breathing out is also hard because the saggy balloon doesn't deflate fully, trapping that stale air inside. So the holes represent the damaged air sacs, if you think about it. It reduces the surface area for oxygen exchange. And over time, this makes it increasingly difficult to get air or enough fresh air in and get rid of that stale air. And that leads to that shortness of breath with even mild activity. So the lungs have to work much harder, causing fatigue, just like blowing up a worn out leaky balloon takes a lot more effort. In this image from our textbook, we can see an example of lungs with emphysema. Let me see what I've got here. Let me get over here. Okay. Oh, see if I can go back. Sorry about that. All right. Whereas when we look at emphysema, it is the abnormal permanent enlargement of gas exchange airways, accompanied by destruction of the alveolar walls without obvious fibrosis. Again, the image from the COPD basics steps to take when living with COPD. You can see the link located in the synchronous session schedule and link announcement. But in emphysema, there is destruction of the alveolar walls, resulting in abnormal permanent enlargement of gas exchange airways. Obstruction results from inflammatory and destructive. Imagine again, your lungs are like a bundle of balloons all tied together. So emphysema, it's as if those balloons have popped and merged into one large floppy balloon. So the popped balloons represent that destroyed alveoli or air sacs. With fewer functional balloons, there is less surface area for the oxygen exchange, and the large floppy balloon doesn't bounce back easily after exhaling. So it traps the stale air inside the lungs. Now, this air trapping overinflates the lungs, putting that strain on the breathing muscles. So over time, it becomes increasingly difficult to blow up the remaining balloons and or get that fresh air in. And that's what leads to shortness of breath, even with minimal activity. Now, the textbook does go over additional examples of obstructive lung disease, so make sure that you're reviewing those as well. One good representation of experiencing what some of these patients can feel like, and I don't recommend that you do this if you have any type of lung issues, and that can be from a cold, bronchitis, or any other chronic disease processes going on. But if you breathe in through different types of straws, breathe in and out through different types of straws. So we have a regular straw, you have even down to like a coffee stirrer. That can actually represent how people are breathing during asthma or during our COPD patients. If they're feeling short of breath, you can sometimes blow out enough, but you can't suck in that good air. So again, you can Google and look at the straw game. But like I said, it's a great representation, and we can have empathy for our patients, because you can imagine how scary that is, and that increased anxiety. That's why we see that anxiety. They're not able to get enough oxygen. So just knowing knowing that, I think, helps us be able to take care of our patients better. So the textbook does use table 35.3 to compare and contrast the clinical manifestations of COPD or chronic obstructive lung disease, looking at bronchitis versus emphysema. So you can see bronchitis has those classic signs of productive cough, and other common symptoms include, we see history of smoking, cyanosis, chronic hypoventilation, polycythemia, cor pulmonale, and occasionally even that barrel chest. So intermittently having wheezing, and late in the disease, we see that dyspnea, while always having for that prolonged expiration. Versus emphysema, we see prolonged expiration is always present. We have that productive cough with infection sometimes, but symptoms include dyspnea, wheezing, history of smoking, have that classic sign of barrel chest, and late in the disease have chronic hypoventilation, polycythemia, cor pulmonale, and uncommonly we see cyanosis. Now, if we do have, I want to share some other resources from the asthma and COPD. Well, actually, it's the American Lung Association, but it displays the asthma and COPD medicines. I have a PDF that they provide to educators and healthcare professionals. I think it's a great resource, again, to help you learn different medications that are out there. Hang on to it for your advanced pharmacology class. It does a great job. For example, treatment of COPD, we have that dyspnea. So we have that breathlessness or difficulty breathing. They have that inhaled long-acting B2 agonists that are that first line treatment. So if you take a look at that chart, it gives you examples of different ones. So if you have a reduced cough, we look at mucolytics, which assist with managing the mucus, like Mucinex or guaifenesin. And that kind of helps break down those proteins in the mucus, making it easier to get rid of. Whereas the use of expectorants, which actually bring moisture to the airways to make the mucus thinner, loosening that mucus can actually make it easier to expel. So you have different examples of that, like menthol, oral hydration, water, and even warm tea, hot tea, inhaling that warm air or moist air. A lot of times you'll see our patients, sometimes, they'll get up drinking. That's why coffee, it's not necessarily the coffee that's doing it. It's that the heat of the coffee. So a long shower or humidifier, and even honey can help with that. So in short, there's different types of medications here. I just wanted to share that as well, because I find it helpful as well. So making sure that you can review that. Now on the back side, it does go over different definitions and additional information as well. And then there's different resources for you. All right, moving on. Let's look a little closer to restrictive lung diseases. So we know a characteristic of restrictive lung disease is decreased lung compliance. So one example of restrictive lung disease is that pulmonary fibrosis. So it's an example of restrictive lung disease. It's shown in this image. In this condition, the lung tissue becomes scarred and stiff, making it very difficult for the lungs to expand fully during inhalation. This decreases the compliance or increased stiffness of the lungs, actually impairs the ability to take that deep breath, and leads to shortness of breath and reduced oxygen levels in the blood. So a few others that we can include is like aspiration. So when we think of aspiration, which is that passage of fluid and solid particles into the lung. It accounts for 5 to 15% of that community acquired pneumonia cases, especially in our older population. Atelectasis is another example, and that's that collapse of the lung tissue. Atelectasis causes that VQ mismatch, leading to hypoxemia. There are 3 different types of atelectasis. We can have obstructive, compression, and even surfactant impairment. Now, another example, we have idiopathic pulmonary fibrosis or IPF, and that's the chronic progressive scarring of lungs without a known cause. Um, Pneumococcus is that caused, it's caused by inhaling that dust particles like coal dust or asbestos fibers. We have sarcoidosis, which is the abnormal inflammatory cells from granulomas in the lungs and other organs. We think of obesity. So we talked a little bit about that as an example, and that's that hypoventilation syndrome, obesity hypoventilation syndrome, and that's that excess weight actually impairs the ability to fully expand the lungs. Now, there are neuromuscular diseases like muscular dystrophy, myasthenia gravis, that actually weaken the respiratory muscles, bronchiectasis, which if we remember, that is the persistent abnormal dilation of the bronchia. It usually occurs in conjunction with other respiratory conditions that are associated with. So thinking about that now, kyphoscoliosis, which is that severe curvature of the spine that restricts the lung expansion. So these are key features. Some of the key features of restrictive disease is that they limit that ability of the lungs to fully expand in that inhalation, reduces that lung volume, and impairs the oxygenation. So remember that straw game I mentioned? Imagine trying to breathe through that coffee stirrer straw. So that is what they're trying to do. If you take a coffee stirrer, again, I wouldn't recommend doing this if you have any type of issues like asthma or chronic disease or even a cold or a cough, but trying to breathe in through that straw, you're only able to get in so much. Another way to think about it is imagine your lungs are like a sponge. So in a healthy state, that sponge is soft and pliable and able to expand fully when you squeeze air into it. With restrictive lung disease, that sponge becomes stiff and rigid and it loses its ability to expand properly. So no matter how hard you try to squeeze the air into the sponge, it can't inflate. It can't completely due to that stiffness and scarring of the material. Now, this limits that amount of fresh air that can enter, making it very difficult to breathe deeply and get enough oxygen. So that sponge loses its elasticity, restricts its capacity, and just like stiff and elastic lungs restrict the breathing capacity in restrictive diseases. Now, a few other pulmonary diseases we'll talk about just really quickly. So we have pneumonia, which we know is a lower respiratory tract infection. It can be caused by mycoplasma or bacteria. It can be caused by viruses, fungi, protozoa, even parasites. So typical symptoms include that chest pain, the pleuritic chest pain, cough. It can be productive or non-productive and viral, if we think of that, and rales. So that crackling sounds heard on inspiration. And it can be lobar pneumonia, where presents in just part of the lobes or a large area of the lobe of the lungs. It can impact the bronchi, causing acute inflammation. Now, pneumonia can be categorized by two different ways. It can be categorized by community acquired or CAP or hospital acquired, what we call as a HAP or HAP. And we assess and investigate to see if pneumonia is something that is community or acquired or hospital acquired or healthcare acquired, because we have to monitor that and hospitals actually have to report those. So in CAP or community acquired pneumonia, one of the most common is bacterial CAP, and that's typically in adults. We see Streptococcus pneumonia. Community acquired is defined as pneumonia that is acquired outside of the hospital or healthcare setting. It's one of the most common reasons for hospitalization in the US. So, risk factors for pneumonia include age below 5 or above 70. So, we have patients that are compromised in immunity level, underlying lung diseases, alcoholism, altered consciousness, impaired swallowing, If you're a smoker, that increase your risks. Malnutrition, immobilization, underlying cardiac or liver diseases, and even residents in nursing homes or extended care facilities. Other risk factors include the use of gastric acid suppressive agents or benzodiazepines as well. Now, on the opposite of that, we have the healthcare acquired pneumonia, which is the most common etiological microorganism is that Staphylococcus aureus and MRSA, other ones, Acinetobacter, Klebsiella pneumoniae, and then we even see Enterococcus coli. So there's several different ones, but those are some of the main ones that we see. These microorganisms also cause pneumonia in individuals who recently have been discharged from the hospital and or who live in long-term care facilities. So in this algorithm or this image that we see, it's an algorithm from the textbook which reviews the pathophysiological course of bacterial pneumonia. So this next image that we have here is just an image of a chest x-ray with a patient with viral pneumonia. All right. So other content to know and study include that pulmonary edema, pulmonary embolism, and pulmonary effusion. So you think about pleural effusion. So pleural effusion is the presence of that fluid in the pleural space. The source of the fluid is usually blood vessels or lymphatic vessels lying beneath the pleural space. Pleural effusions can be divided into 5 different categories based on their mechanisms. And then we have pulmonary edema, which pulmonary edema is a condition where excess fluid accumulates in the air spaces and tissues of the lungs. This fluid buildup occurs when the normal mechanisms that regulate fluid balance in the lungs becomes disrupted. So the most common cause is an increased pressure in the blood vessels of the lungs, often due to like heart failure. This elevated pressure forces fluid out of the lung capillaries and into the airspace. So other causes include injury to the lung capillaries, allowing fluid and proteins to leak out, or blockage of the lymphatic drainage system. With fluid filling the alveoli, that gas exchange becomes impaired, and that's what leads to the shortness of breath and potential respiratory failure if left untreated. All right. This table is from the textbook. It just shows the mechanisms of pleural effusion. It's in table 35-2 if you're interested as well. And then do you have an algorithm 35-2, which just shows the pathogenesis of pulmonary edema. All right, pulmonary embolism, or a PE, we know as a blockage in one of the pulmonary arteries inside the lungs. It usually is caused by a blood clot that travels from elsewhere in the body. The clot obstructs the blood flow to that part of the lung, and that is what impairs the lung's ability to oxygenate blood and remove that carbon dioxide. Now, this can lead to shortness of breath, chest pain, coughing up blood, low levels of oxygen, and potentially life-threatening complications if the clot is large or multiple clots are present. So most PEs originate from DVTs or deep vein thrombosis in the legs, where a clot breaks off and travels to the lungs. Risk factors include prolonged immobility, recent surgery, cancer, obesity, and even inherited clotting disorders. A good table in the book too is a table 35-1. It just does causes of hypoxemia. So a couple other things I just want to talk about quickly. Remember looking at some of your terminology like Kussmaul breathing. We know also known as Kussmaul respirations. It refers to a pattern of deep labored breathing characterized by an increased respiratory rate and depth. It's a form of hyperventilation that occurs as the body attempts to compensate for metabolic acidosis by expelling that excess carbon dioxide. Now, the rapid gasping breaths help lower the levels of carbonic acid in the blood, which can raise the pH and partially correct the acidosis. We see labored respirations. And that's referring to breathing that requires increased effort and or work of breathing. This can manifest as rapid, shallow breaths with the use of accessory muscles like the neck and abdominal muscles. Labored breathing often indicates an underlying condition that impairs normal respiration, such as an airway obstruction or decreased lung compliance, or even an increased airway resistance. Now, in hypoxemia, again, the table 35.1 kind of looks at the causes. Hypoxemia refers to low oxygen levels in the blood. It occurs when there is inadequate oxygenation of the blood as it passes through the lungs. So, this can be caused by conditions that affect the lungs' ability to transfer that oxygen into the bloodstream, such as lung diseases like COPD, pneumonia, pulmonary edema. Hypoxemia can also result from low oxygen levels in the air being breathed. If we think about high altitudes, okay? So symptoms can include that shortness of breath, rapid breathing, that cyanosis or bluish discoloration of skin, and even that confusion or impaired mental status if severe enough. Now, prompt treatment is very important to restore proper oxygen levels and prevent complications from that lack of oxygen delivery to those vital organs. Typically, we see a tachycardia. That increased heart rate is often one of the first early signs of acute hypoxemia. So, when we think about oxygen levels in the blood dropping, the body actually tries to compensate by increasing the heart rate to circulate more oxygenated blood. So, other early signs of hypoxemia can include restlessness, inability to concentrate, dizziness, and increased respiratory rate as the body attempts to take in more oxygen. But remember, tachycardia is one of those first physiological responses as the cardiovascular system is trying to help maintain adequate oxygen to deliver to the tissues when hypoxemia starts to develop. All right. The last thing we're going to look at is the pathophysiology of tuberculosis or TB. It's a very complex process that primarily affects the lungs. When we see Mycobacterium tuberculosis or bacteria are inhaled, okay, so this image is a great visual. They reach the alveoli in the lungs. The body's immune response is triggered, and with alveolar macrophages engulfing the bacteria. This initiates the inflammatory response, attracting more immune cells to this area. Now, the key steps in the pathophysiology include the granuloma formation, and those infected macrophages or the T lymphocytes and other immune cells cluster together, forming a structure called a granuloma or tubercula. This is the body's attempt to contain that infection. Now, casus necrosis, this center of the granuloma undergoes necrosis, and this creates like a cheese-like or casus material. The material contains dead host cells and bacteria. Now, fibrosis and calcification, in many cases, that granuloma becomes surrounded by fibrosis tissue and may calcify, and that effectively contains the bacteria. Now, cavity formation in some cases, particularly when the immune system is compromised, that casus center can liquefy and rupture. This releases the bacteria into the airways and forming cavities in the lung tissue. Now, the lung damage occurs through several mechanisms. So we see direct tissue destruction by the multiplying bacteria. We see immune-mediated damage from the inflammatory response. We also see the structural changes due to the granuloma and formation and fibrosis. And then cavation leading to the loss of functional lung tissue. Now, this damage can result in reduced lung capacity, impaired gas exchange. It increased susceptibilities to other respiratory infections and potential for spread to other body parts of the body if left untreated. So the extent of lung damage depends on the individual's immune response and the timing of treatment. So early diagnosis and appropriate treatment can significantly limit the progression of the lung damage in TB. So All right. I hope you all have a wonderful week. Please remember, if you have questions, reach out to me. One of the best ways, or the best way to reach me, is via email. If you have any questions, don't hesitate. Thank you so much.